First, I'd like to thank the organizers for inviting me to this meeting. I think it's a very important meeting. And basically, I'll be talking about some very good news about reducing HIV transmission among Peewit in the city of Hai Phong, Vietnam. The study is called the DRIVE study, standing for Drug Use and Infections in Vietnam. And the purpose was to end the HIV epidemic among people who inject drugs in Hai Phong. Hai Phong is a city of 2 million people. It's the major port for the northern part of Vietnam, and there are approximately 10,000 people with histories of injecting drug use in the city, and about half of those, about 5,000, are actively injecting drugs at any one point in time. This is the large research group that has been working on this study since 2013. It includes people from Vietnam, US, and France. And basically, we've studied combined prevention in combination with very large community surveys to show that the HIV epidemic has actually ended among Peewit in Hai Phong. We know that combined prevention has been very successful for reducing HIV transmission among Peewit in high-income settings. The combined prevention includes syringe exchange program, methadone maintenance programs, and antiretroviral treatment for HIV-positive persons. We use New York City as a model for DRIVE. Combined prevention has been implemented in New York, and the rate of new HIV infections went from 4 per 100 person years just prior to implementing syringe exchange to 0.4 per 100 person years currently. So in New York, we saw a 99% reduction in the rate of new HIV infections. There are, however, important issues in transferring successes in high-income settings to low and moderate income countries. These include limited financial resources, limited trained personnel, often limited research capacity, and of great importance, severe stigmatization of HIV and injecting drug use. This often creates difficulties in reaching Peewit for both services and participating in research. And then many countries in Southeast Asia have counterproductive practices for working with HIV among people who inject drugs. These particularly include incarceration in prisons and in detention centers. Vietnam does have this policy of using detention centers called 06 centers. We wanted to set up some clear criteria for what we meant by ending an HIV epidemic among Peewit. We wanted to reduce HIV incidence to 0.5 per 100 person years at risk or less. We wanted to reduce the percentage of people who were HIV positive and not at viral suppression to 7.5% or less of the total Peewit population. We wanted to reduce the percentage of HIV seropositive Peewit not at viral suppression and engaging in distributive sharing of needles and syringes to 2% or less. So that these would be the people who are capable of transmitting the virus by passing on their used needles and syringes to other Peewit. We committed ourselves to these criteria. We published them in clinicaltrials.gov and also in a paper in The Lancet. We felt we needed very large surveys of Peewit in Hai Phong. We wanted to identify large numbers of Peewit in need of services and then to assist them in obtaining those services. We wanted to follow large numbers of HIV seronegative Peewit to measure HIV incidence with precision. We felt that if we wanted to make this study serve as a policy guideline for the rest of low and middle income countries, we needed very, very good, very, very large numbers of PWID in our studies in order to be convincing at a policy level. We used respondent-driven sampling and super recruiters in our studies to recruit PWID. In respondent-driven sampling, you start with a number of seeds, people who inject drugs who have large social networks. They participate in the study, and after they participate, they're given a number of coupons to recruit additional PWID. So we don't use staff recruiting, we use PWID to recruit their peers into the study. The participants are paid for their own time and effort in the study, and they're also paid for recruiting new participants. We worked in collaboration with community-based organizations to assist in the seed identification and recruitment and survey administration. I want to emphasize that the CBOs were really critical what we're doing. They help establish trust between the research group and PWID in the community, and they were responsible for administering parts of the survey. When we enroll people in our surveys, we use a fingerprint identification to make sure that people didn't enroll in one survey more than once, and so that we could link people who participated in one survey to the next survey. Because we were using community-based organizations, we had no problems in having PWID give us a fingerprint identification. We did assure everyone that the fingerprints would not be shared with anybody outside of the research group, but we did feel that it was very, very important to be able to identify individuals, and because of our community-based organization support, we did not have any problems in using fingerprint. We gave out 3 coupons per participant for recruiting new participants, and that worked fairly well for about the first 1,000 people in each of the surveys. Then it became very difficult for PWID to recruit new participants, and so we adopted a strategy of using super recruiters. We talked to participants coming in. We asked them, how many people can you recruit? Some of them said, I don't think I can recruit anybody else, and so we didn't give them coupons. And we had some people who said, well, I can recruit 10 to 20 new participants. So we gave them 10 to 20 coupons for recruiting. This shows the number of recruits per week for our 3 large surveys to date. You can notice that within the first 2 to 3 weeks, we were typically recruiting about 200 subjects per week. And then it drops down after week 5, and then around week 6 or 7, we started using super recruiters. That bumped it back up, but eventually it became very difficult to recruit new people, and to the point where it was not worthwhile to keep our study sites open. But we did get more than 1,400 people in each of these 3 large surveys. So we did get the very large numbers that we felt we needed to make a convincing policy argument that we knew what was happening in the city of Haiphong. We looked at some of the reasons why it was difficult to recruit through RDS continuously. There was police suppression of the drug hotspots where drugs were sold. That limited the ability of PWID to make contacts with other PWID. There were transportation issues to getting people to the research sites. There were concerns about maintaining confidentiality of drug use. And of course, people injecting drugs have a lot of competing interests for their time, in addition to participating in research studies. Because we did not use standard RDS methods for the entire recruitment period, we treated our samples as convenience samples and not as RDS samples. However, we did look at the RDS diagnostics to see how the surveys were doing. In an RDS study, you want homophilies to be very low. A homophily is the measure of whether an individual subject will recruit people very similar to the individual subjects. So you want those to be as low as possible. You want recruiting to be on a more or less random basis. All of our homophilies were very, very close to zero. And in an RDS study, you want equilibrium to be achieved fairly quickly. We did it in either 1 to 2 ways. That means that the characteristics of the total sample really do not change from the time you reach equilibrium to the end of the study. When we recruited people through these large surveys, we also selected seronegatives to participate in cohort studies. We had a total of 896 people who were HIV negative who participated in our cohort studies. They had research visits every 6 months, and we had 766 with at least one follow-up visit. Because we allowed individuals to participate in the 3 different surveys, we had 281 people who participated in more than one of the 3 RDS surveys. They generated 377 person-years at risk, and there were no HIV seroconversions among these 281 people participating in multiple RDS surveys. In terms of people we put in the HIV negative cohort studies, where we studied them every 6 months, there was 1 HIV seroconversion among 766 persons who generated 1,120 person-years at risk. So basically, our HIV incidence was about 0.1 per 100 person-years at risk, or about 0.1% were getting infected per year. In terms of ending the epidemic, in our criteria, we wanted to reduce incidence to 0.5 per 100 person-years at risk. We actually found an incidence rate of 0.1. We wanted to reduce the percentage of HIV positive PWIT not at viral suppression to 7.5% or less. It's actually been reduced to 3.1%. The 90-90-90 goals for testing, treating, and achieving viral suppression have been reached for PWIT in Haiphong. And we wanted to reduce the percentage of HIV seropositives who are not at viral suppression, but engaging in distributed sharing, potentially transmitting to others, to 2% or less. It's actually less than 1%. Okay. So in terms of our next step, we have 1 more large survey to be done that starts in this month. We have completion of final cohort study visits. We need to pay attention to the changing in the funding mechanisms, because methadone maintenance and ART are changing to in-country funding. We need to pay attention to increasing methamphetamine use, which tends to lead to aggressiveness and may reduce viral suppression. And we need to make sure that we don't have another outbreak, which would have very bad policy implications. We will be moving to new areas in Vietnam, again using large-scale RDS surveys. And in those surveys, if the new area is at an end of the epidemic, we shift efforts to monitoring and maintenance of efforts. If the end of the epidemic criteria are not met, we would use CBO support to reduce barriers for PWIT accessing services. Basically, the lessons of DRIVE is that first and most importantly, it is possible to end an HIV epidemic among PWIT in a middle-income setting. There is a need for maintenance prevention efforts. You don't stop simply because you've reached an end of the HIV epidemic. And there's a need for transferring the triad methods to other areas of Vietnam and elsewhere. We're currently planning on starting work in neon crops. Thank you very much.